Regarding the anaplastic carcinoma of the thyroid, the prognosis is very poor. Treatment is, in majority of the patients, is palliation. And the palliative therapy for anaplastic cancer of the thyroid is one is the biopsy. You should confirm it. So it may be a lymphoma, and then the treatment will be totally changed, and that can be treated with the chemotherapy. Non-Hodgkin lymphoma is also a very aggressive tumor. It presents as a mass in the thyroid gland. So before you declare as an anaplastic, you must have got a FNC, which can either tell you the undifferentiated cells or the lymphocytic, or you can, if it is a doubt about the lymphoma, you can take an open biopsy of it. If it turns out to be lymphoma, I think that can be easily managed with the chemotherapy. Usually the cancer of the thyroid, which is lymphoma, is non-Hodgkin lymphoma. If it is anaplastic, the treatment totally supportive. It is usually beyond the resections, and the palliative surgery thyroidectomy is no operation. If it is possible to resect, you resect it and do the total thyroidectomy. If you cannot do it, then don't touch it. Tracheostomy is very difficult in doing the anaplastic cancer because the tumor has wrapped the whole trachea from front to sides, and also involving the carotid sheath. The treatment will be radiations or chemotherapy as a palliative treatment. Hardly you can able to do the tracheostomy. So the prognosis is worse in anaplastic cancer. Lymphoma has a good prognosis if it is diagnosed by open biopsy or true cut, and that can be managed with the chemotherapy. The, the second deposits in the cancer of the thyroid are very rare, and usually primary is either the carcinoma of the trachea, which has involved the thyroid gland, or carcinoma of the larynx. Sometimes you can get also the leukemic deposits. As a case of leukemia, you can have got a thyroid swelling where the leukemic deposits are present as a nodule in the thyroid. When you do the lobectomy, you find that this is a case of leukemic deposit, but I think the FNC is very helpful to see, and of course in these patients one should very closely look into the blood picture of CPC count or blood count. You should see if it is raised, then this is a case of a leukemias, and if you operate on them, there is a blast crisis, and the patient may have got a leukemic deposit which will be in even the retina, and you may lose the eyeball. So one should always avoid in leukemia to operate upon the patients when it presents as a thyroid swelling and it is proven that it is not a primary tumor of the thyroid gland. One should hold the knife and not do anything and address the disease, which is the main concern. That is about the cancer of thyroid. A few things I want to tell you about this one. The prognosis of the papillary carcinoma of the thyroid is an excellent. The only thing which worries having a poor prognosis is the extra thyroidal spread in the tissues like esophagus, trachea, and the carotid sheath. The presence of the enlarged lymph node or the stage of the disease doesn't matter. It is the extra thyroidal spread which is a killer in papillary carcinoma of the thyroid, not the stage of the disease. You can have a good prognosis, even the cervical lymph nodes found enlarged, and you do the block dissection, the patient may live longer. But if the tumor has invaded the trachea, the esophagus, or a carotid sheath, then it means that the prognosis is poor, because there are higher chances of local recurrence, which can lead to strangulation of the patient or a tumor has invaded the trachea, recurrence, and that can cause severe degree of hemoptysis and the later on bronchopneumonia or the asphyxia, which is a killer of this patient, and you can't help it out if the disease is so extensively involved the surrounding tissue, especially the hollow tubes, trachea, esophagus. Patient doesn't die because of the hematogenous spread, which is unlikely in case of papillary carcinoma. Only 7% of the cases papillary carcinoma do spread by the blood-borne, but predominantly by lymphatics and the direct spread. Other important thing is it is super sensitive to radioactive iodine, which you can do after the completion of your operation, and you keep time period about 4 to 6 weeks. Let the TSH should go up, so that will be help and facilitate to uptake the radioactive iodine by the residual thyroid tissue in the thyroid bed or in somewhere else in the surrounding tissues. So that is the very important. Every well differentiated carcinoma of the thyroid, which is more than 1 centimeter, after doing total thyroidectomy, you must ablate with I-131. That is preceded by the lapse of 4 to 6 weeks. Let the TSH should go up, and then you get a total body scan and give ablative dose of radioactive iodine. After that, you can put the patient on full dose of thyroxine, which is required by the body. The thyroxine will act as an anti-cancer drug because it suppresses the TSH, and at the same time it also fulfills the requirement of thyroxine for the rest of life. The dose you can give up to 125 microgram per day, because there is now a new concept is that don't give a higher doses of thyroxine even in this patient of papillary carcinoma, because the complications are much more than what is the advantage of giving the high dose of thyroxine, because the patient can develop osteoporosis, fractures, and the cardiac arrhythmia like atrial fibrillation. So that may be a killer of the patient. So one should optimize the dose of thyroxine between 100 to 125 microgram, and the TSH level should not be less than 0.2. There's no need to bring it down to the 0.01 level, because that is more detrimental and lethal to the body regarding the fractures and the cardiac complications. Follicular carcinoma of the thyroid is a bit more aggressive than the papillary, occur in the middle age group, present as a salty nodule, or present with hematogenous metastasis either in the scalp, bone, brain, spine, or in the lung. Total thyroidectomy is the answer. There is no need to do the lymph node block dissection because it is hardly spread by the lymphatics. The main spread is the hematogenous spread. Total thyroidectomy followed by full dose of radioactive iodine for the ablation of the secondary deposits anywhere in the body or in the thyroid bed. Prognosis is not as good as in papillary carcinoma, but anyhow there is a 5-year survival rate is more than 50%. Medullary aggressive surgical treatment in medullary carcinoma will bring the much relief to the patients. Inadequate surgery followed by a high incidence of loco-regional recurrence in medullary carcinoma. Aggressive approach with total thyroidectomy and block dissection may be unilateral and bilateral, or sometimes extended block dissection involving the L6 lymph nodes should be taken in a section. Bad thing about it is it's neither sensitive to radiotherapy nor sensitive to I-131. Surgery is the main role, and if the recurrence occurs, answer is radiotherapy or some sort of chemotherapy for the palliation. Recurrence, if it's possible to resect it, is the first thing, but usually when the recurrence occurs in the thyroid bed, there are higher chances of damaging the recurrent nerve and the parathyroids. So it is better not to touch it because the quality of life becomes worse. If the recurrence occurs in the lateral part of the neck, you can revise the block dissection if it has not done properly in the first hand. So do again and revise it and aggressively treat with convert this block dissection which was done before, maybe cherry picking or flower picking. You should convert it into a classical block dissection of neck. So you eradicate the disease in the paracentral or the lateral part of the neck by doing the block dissection. Anaplastic prognosis is very poor. Patients come in 3 months' times. By the time the patient reaches the hospital, it is beyond the scope of resection. So when there is no resection, no hope. Treatment is palliative. We need irradiation chemotherapy. And in very rare instances, if the trachea is visible, you can do the tracheostomy, which is very, very difficult in the routine circumstances. One should avoid to touch the thyroid gland in these situations because just like an iceberg. Lymphoma of the thyroid, usually non-Hodgkin lymphoma, difficult to diagnose. You have to do the lobectomy and hysterectomy if it's permissible, and histology shows this is non-Hodgkin lymphoma. There's no need to do the total thyroidectomy. You can look after with chemotherapy because majority of the non-Hodgkin lymphoma is in the thyroid. That is a brief of this cancer of the thyroid. One thing you should always remember, whenever you find a solitary nodule, solid, euthyroid, solid means on scan it is solid. Clinically or the thyroid function is euthyroid. And no facilities are available like cytopathology is not available. The minimum operation you should do for a solitary solid nodule is the lobectomy and the hysterectomy. That is the right answer for that. Because if it turns out to be cancer, you can revise the operation and convert it into total thyroidectomy. And if it turns out to be benign like a follicular adenoma or colloid goiter or the focal thyroiditis, answer is you can leave alone and put the thyroxine just to maintain the level of the TSH so that the patient should not go, the thyroid gland should not go compensatory hypertrophy over a period of 5 to 7 years. That is all about the cancer of thyroid. The incidence of recurrence is high in cancer of the thyroid if the size of the primary tumor is more than 1 centimeter. One. Second, it has got a extra thyroidal spread and age is below 20 or above 50. High chances of recurrence. More recurrence likely to occur in the patients who has got the extra thyroidal spread. That is very significant bad prognostic factor which may lead to recurrence of the cancer. All the cancer after the treatment they should put on thyroxine because thyroxine is very important to maintain the level of thyroid functions which are, otherwise the patient will go into hypothyroidism, which is another problem to cause cardiac failure. In cancer of the thyroid, surgical treatment is the mainstay. Surgeon, whatever he does, good or bad, that will reveal in the form of the result. Good surgery, good treatment, proper treatment at right time, results are excellent. If the surgery is not performed properly, the patient may end in disasters. Recurrence, ruthless recurrence can occur, which is difficult to treat second time. And the end result is the same. The first operation should be the last operation. Nothing like the first operation and nothing like the good operation, which is this statement holds in every sort of surgery, maybe benign disease or for the malignant disease, which is more true for the malignant disease because there is no chance at all. Because redo surgery in the head and neck cancer is very, very difficult, and it will not produce the same fruitful results as you do the surgery in the first time by the people who know the job. Thank you very much.